Many of you who may not know, prior to joining the legislature and prior to becoming an attorney, I started out life as an X-ray technologist. And while I was at Licensure General, I eventually went to school, had a degree in healthcare administration, and became the manager of support services for radiology at Licensure General. In those duties, I was the PACS, the Picture Archival Communication System, which is digital X-rays, system administrator, as well as the individual responsible for the billing, coding, and charging for all of the radiology procedures done in the health network. The reason I share that is because that's really where the interest in this bill for me began. Because even nearly 20 years ago, we were already doing a version of telehealth at that time. We had in our PACS network, we had multiple sites. We had outpatient clinical sites. We had the hospital proper, and we would share radiology images over the network at that time. We would archive the images at the hospital. We would distribute them out remotely to the multiple facilities or the outpatient centers or physicians' offices where patients were going. And we were responsible for all of that. And the reason I share that is because this is not necessarily a new technology. Some of the issues that we'll encounter as we discuss the bill may be new, but I would actually offer that all we need to do is think about them a little differently and come up with slightly different solutions, because we were able to overcome them nearly 2 decades ago when we were there, and I think we'll be able to overcome them today. When we were at the system, it was fairly easy in terms of reimbursement because everything was in network. It was the same providers, it was the same radiologists, and everything was consistent inside our system. As I left that job and decided to go to law school, and prior to running for office, I worked at a facility where we used what they called Nighthawk services, which were off-site radiologists, oftentimes in Australia because of the time zone differences, where when I worked night shift, we would actually send our radiology films via the internet to a secure server, have them reviewed. We would give a preliminary report to the emergency room at that time, and then they would be reread in the morning, and then we had a quality control process in place to ensure that nothing was missed. Now, that certainly raises some questions of state licensure and credentialing and a whole host of other issues, but the important factor to understand is they were all taken care of 15 years ago. And they were consistent with delivering quality patient care, timely film interpretation, and getting patients on their way. Anytime that we discuss issues like this, and this is really, I think, the important part, is there's 3 components to the delivery of healthcare. And every time that we make a change, you're going to impact at least one of them. And they are as follows. It's cost, quality, and access. And every component that we work on will influence one either to the good or to the bad as you move each one. I would offer that this actually offers opportunities for increased access, also offers opportunities for lowering costs potentially, and also improving patient access in terms of rural and urban areas that may not have the opportunity to have specialists. If you look at our medical population, it unfortunately is trending upward in terms of age, and there's not as many people coming in at the bottom as are going out at the top in terms of retirement. So when you look at it, I think this is a new tool in the toolbox that could be expanded potentially to better allow healthcare providers to continue to meet our growing healthcare needs and improve patient care. I think it can greatly enhance the outcomes in terms of timeliness, quality, and access for delivery of service, particularly in rural areas. The example, while it was not one of the chairman's, it was a demonstration of telemedicine that I saw 2 years ago with the policy committee, was where you have cases where individuals might have a stroke and you need to go in for a specialized kind of treatment that can be very expensive in terms of running blood thinners. Well, if you're at a remote facility, there's transportation costs involved, and you need to make sure that that individual is having a stroke. So they would at first do a telemedicine review to make sure that the symptoms were consistent with what that was prior to moving the patient. It was a very unique approach. They were able to look at the CAT scan images, the CT images of the head. They were able to do the evaluation via real-time video feed, and then they would make a clinical determination as if they were there. And they were able to deliver better patient care. And if it wasn't a stroke, then they didn't have to unnecessarily burden the patient or increase costs by moving them. And I think that's a good example of where it can improve patient care and potentially lower costs. I also think that telemedicine has potential to reduce the loads that we're currently experiencing in our ERs, in our emergency rooms. When you look at what a lot of folks use emergency rooms for, unfortunately, it's not always truly emergent cases. That's something that I know Representative Gillespie dealt with in his prior career, and as did I in terms of our volumes. When you looked at the volumes of cases that come to the hospital, they're not always being cared for in the appropriate places. Many individuals don't have a primary care physician, so they end up using the emergency room as one. And that's one of the most expensive places to deliver care. So if you can increase opportunities to deliver primary care in a more cost-effective setting, you will, through that, overall lower healthcare costs. I know that had our staff research it. Mental health is a particularly great field where I think this could be expanded. Telemedicine, wellness intervention, triage referral program was run in Texas, where they were able to administer services. And I know that in the Norristown Area School District and Children's Hospital of Philadelphia, they piloted a program here. So I think that those are things that we can look at in terms of how were these issues of credentialing, licensing, reimbursement, and costs, how were they handled and how were they addressed in terms of any of the questions that we had. The other area is a particularly personal one for me because it's the delivery of senior care services. I had a close personal family friend who unfortunately, through miscommunication between the long-term care facility that she was at and the hospital where she was supposed to go for follow-up after a very complicated surgery, where the physicians worked miracles and saved her life, she was sent to a long-term care facility to rehab. She did not get the appropriate follow-up and care that she needed, and she ultimately developed other complications related to the missed appointments and then passed away. And in a case where you didn't have to physically transport the patient back and forth from the long-term care facility to the hospital, I think that there's an opportunity for improved patient care, improved outcomes, and ultimately lower costs as well. So to bring everybody back to those three issues, I think this potentially addresses costs, it potentially addresses access, and it potentially addresses quality. And I think there's opportunities in each of those. I think too often here in the legislature, we get inundated with all of the reasons why we cannot do things. You know, we'll hear a lot of reasons why we shouldn't tackle an issue. And you know, this issue is one that I started a while ago because of my own personal background, but I was more than happy to defer to Representative Quinn and the other individuals because they had more of a head start on me in terms of drafting, and I think they were better positioned to move the issue forward. I want to thank her for her work on this, and more than happy to work with them as we move this through the process. I'll be happy to share any personal experiences that I've had through my nearly 2 decades in the healthcare field. But rather than focus on all of the issues, and I can briefly run through them because I think it's important, because I'm assuming I have not read your binder since I'm not a member of the committee, but these are the issues that I dealt with 15, 20 years ago when I was working there. You know, there's issues of licensing and credentialing. There's potentially issues related to the resolution of the computer monitors that things will be viewed on. There's issues of billing, coding, and charging, provider and network issues. There's contractual relationships with those provider and network issues, and there's HIPAA and privacy concerns. All of those issues are addressable in my experience. We addressed them when I was at Licensure General back in 99, 2000, and 2001. I think that we can still address them today. And my word of encouragement to the committee as you work through those issues is our law should encourage this type of development and make it so that this technology can be used and expanded on behalf of the patients and on behalf of quality patient care. And we shouldn't have laws in place that simply discourage new development, because I think we've all have experiences outside of this particular realm where we all agree that things haven't been updated since the 80s or the 90s, and technology has far outpaced the ability of our statutes to keep up. And that's probably one of the biggest complaints that I hear from individuals outside of the legislative process is, why hasn't that law been updated since 1984? Or, some cases, we come across stuff, the hospital licensing bill, the last big omnibus rewrite that myself and Representative DeLissia worked on, that took 3 decades to get done. And unfortunately, technology moves at a much, much faster pace than that. So I just encourage everybody, look at the potential. Let's solve the issues, because I think they're absolutely solvable. Ask good questions, and let's focus on the solutions, because I think that's what our constituents who ultimately, hopefully aren't patients, but when they are, they're going to want that to be the answer.